You can start, I think.
Sir, am I audible, sir?
Yeah.
Good morning, everyone. I am Dr. Ahad Khan. I feel privileged to be starting this year, that is 2023's Tuesday academics. Our topics of discussion first are tropical fevers, and today I will be speaking about dengue fever. So, what is dengue fever? Dengue fever is caused by a mosquito-transmitted virus and the leading cause of arthropod-borne viral disease in the world. It is also known as breakbone fever due to the severity of muscle spasms, joint pain, dandy fever, or 7-day fever because of the usual duration of the symptoms. Aedes mosquitoes transmit the virus and are common in the tropical and subtropical parts of the world. Let's talk about etiology and epidemiology. Dengue fever is caused by any four distinct serotypes of dengue virus, DENV1 to 4, of single-stranded RNA viruses of the genus Flavivirus. Infection by one serotype resulting in lifelong immunity to that serotype, but not to others. So it is the fastest spreading mosquito-borne viral disease affecting more than 100 million humans annually. The primary vectors of the disease are female mosquitoes of Aedes aegypti and Aedes albopictus. Transmission takes place through bite of an infected mosquito to human. Transmission by perinatal, blood transfusions, breast milk, and organ donation routes have also been noted. Let's talk about pathophysiology, a brief pathophysiology. Spectrum of diseases from self-limiting dengue fever to hemorrhage and shock may be seen. The typical incubation period is 4 to 7 days, but it can last or vary from 3 to 7 days. 3 to 10 days, sorry. The exact course of events following the dermal injection of the virus by mosquito bite is unclear. Skin macrophages and dendritic cells appear to be the first targets. It is thought that the infected cells then move to the lymph nodes and spread through the lymphatic system to the other organs. Viremia may be present for 1 to 2 days before the onset of symptoms. A complex interaction of host and viral factors then occurs and determines whether the infection will be asymptomatic, typical, or severe. The severity of the disease results from a secondary infection with a second strain of the virus and patient's immune response, or it may be both. Dengue hemorrhagic fever and dengue shock syndrome occur due to increased capillary permeability and vasodilatation 3 to 7 days after the start of illness, caused by release of mediators like tumor necrosis factor alpha 1 and interleukin 1. So let's come to the presentation and clinical features. There's a fever which presents as a temperature returns to normal after 5 to 6 days and rises again about 5 to 8 days after onset. It is called classically it is called saddleback form, and there is a headache, which is more of a frontal headache. Then other symptoms are retroorbital pain, myalgias, arthralgia, severe backache, and bone pains. A rash will be seen. There is a positive tourniquet test. Bleeding manifestations may be present. Abdominal pain, decreased urine output despite fluid intake. These may be the signs and symptoms. Based on the signs and symptoms, we can classify dengue into dengue with warning signs. First, normal self-limiting dengue, then dengue with warning signs, and then severe dengue. So dengue with warning signs will present with warning signs such as abdominal pain, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restlessness. There will be hepatomegaly seen of more than 2 centimeters minimum. There will be increase in hematocrit with decrease in platelets. Whereas in severe dengue, we see severe plasma leakage leading to shock, fluid accumulation with respiratory distress, severe bleeding as evaluated by clinician, or severe organ involvement where AST and ALT the enzymes are elevated in thousands. There may be CNS manifestations such as impaired mental status. In heart, we can see arrhythmias, and other organ involvement may also be seen. So severe dengue can be classified into three phases: febrile, critical, and convalescence. In febrile, the fever lasts for 2 to 7 days. Hallmark features are high fever and symptoms consistent with either dengue fever. Potential complications: dehydration due to decreased fluid intake, emesis, and increased metabolic state. Convulsions due to high fever, rarely severe hemorrhage. In critical phase, uh, this in this the hallmark feature is plasma leak that lasts for 1 to 2 days. Hallmark features are normal or subnormal temperatures, varying degrees of plasma leak into pleural and peritoneal spaces, varying degrees of hemorrhage, risk of developing shock and death. Potential complications include unrecognized severe plasma leakage or hemorrhage leading to shock, such as there may be intracranial bleed, metabolic abnormalities such as hyponatremia, hypoglycemia, metabolic acidosis. There may be coagulopathy with abnormal INR or prothrombin time, permanent hepatic failure, prolonged shock leading to death. And in the convalescence or reabsorption phase, which lasts for about 2 to 4 days, hallmark features are a resolution of plasma leakage and hemorrhage. There is stabilization of vital signs, reabsorption of accumulated fluids, including leaked plasma and administered intravascular fluids. There is improved appetite and sense of well-being. Potential complications include intravascular fluid overload due to continual aggressive volume resuscitation during convalescence phase. So there are various diagnostic methods of dengue. Here we'll be discussing about them. So laboratory diagnosis methods for dengue, for confirming dengue virus infection may be involving detection of the virus, viral nucleic acid, and antigen or antibodies, or a combination of these techniques. After the onset of illness, the virus can be detected in serum, plasma, circulating blood cells, and other tissues for 4 to 5 days. During the early stages of the disease, virus isolation, nucleic acid, or antigen detection can be used to diagnose the infection. At the end of the acute phase of infection, serology is the method of choice for diagnosis. So in primary infection, when dengue infection occurs in persons who have not been previously been infected with flavivirus or immunized with flavivirus vaccine, the patient develops a primary antibody response. IgM antibodies are the first immunoglobulin isotype to appear. These antibodies are detectable in 50% of the patients by days 3 to 5 after onset of illness, increasing to 80% by day 5 and 99% by day 10. The IgM levels peak about 2 weeks after the onset of symptoms and then decline generally to undetectable levels over 2 to 3 months. Anti-dengue serum IgG is generally detectable at low titers at the end of the first week of illness, increasing slowly thereafter, with serum IgG still detectable after several months and probably even for life. In secondary infection, during a secondary dengue infection in a host that has been previously infected with the dengue virus, or sometimes after a non-dengue flavivirus vaccination or infection, the antibody titers rise rapidly and react broadly against many flaviviruses. The dominant immunoglobulin isotype is IgG, which is detectable at high levels, even in the acute phase, and persists for periods lasting from 10 months to life. Early convalescence stage IgM levels are significantly lower in secondary infections than in primary ones and may be undetectable in some cases, depending on the test used. To distinguish between primary and secondary dengue infections, IgM to IgG ratio antibody are now more commonly used than the hemagglutination inhibition test. So current diagnostic methods include virus isolation, which is culture, nucleic acid detection, RT-PCR, nucleic acid sequence-based amplification, detection of antigens, serological tests, and hematological tests. So speaking about virus culture or virus isolation, specimens for virus isolation should be collected early in the course of the infection during the period of viremia, usually before day 5. Virus may be recovered from serum, plasma, and peripheral blood mononuclear cells, and attempts may be made from tissues collected at the autopsy. Example, liver, lung, lymph nodes, thymus, bone marrow. Because dengue virus is heat liable, specimens awaiting transport to the laboratory should be kept in a refrigerator or packed in a wet ice. For storage up to 24 hours, specimens should be kept at between 4 degrees centigrade to 8 degrees centigrade. For longer storage, specimens should be frozen at minus 70 degrees in a deep freezer or stored in a liquid nitrogen container. Storage even for short periods at minus 20 degrees is not recommended. Cell culture is the most widely used method for dengue virus isolation. The mosquito cell line C6/36 or AP61 are the host cells of choice for routine isolation of the dengue virus. Since not all wild type dengue viruses induce a cytopathic effect in mosquito cell lines, cell cultures must be screened for specific evidence of infection by an antigen detection by immunofluorescence assay using serotype specific mononuclear antibodies and flavivirus group reactive or dengue complex reactive monoclonal antibodies. Virus isolation followed by an immunofluorescence assay for confirmation generally requires 1 to 2 weeks and is possible only if the specimen is properly transported and stored to preserve the viability of the virus. Next, nucleic acid detection and RT-PCR. So RNA is a heat liable and therefore specimens for nucleic acid detection must be handled and stored according to the procedures described for virus isolation. The in situ RT-PCR offers the availability to detect dengue RNA in paraffin embedded tissues. All nucleic acid detection assays involve 3 basic steps: nucleic acid extraction and purification, amplification of the nucleic acid, and detection and characterization of the amplified product. A combination of the 4 serotype specific oligonucleotide primers in a single reaction tube, one-step multiplex RT-PCR is an interesting alternative to the nested RT-PCR. Compared to the virus isolation, the sensitivity of RT-PCR methods varies from 80 to 100% and depends on the region of the genome targeted by the primers. The approach used to amplify or detect the PCR products. Example, one-step RT-PCR versus two-step RT-PCR. So to avoid false positive results, it is important to target regions of the genome that are specific to the dengue and not conserved among flavi or other related viruses. False positive results may also occur as a result of contamination by amplicons from previous amplifications. This can be prevented by physical separation of different steps of the procedure and by adhering to stringent protocols for decontamination. Next, we'll speak of NASBA, nucleic acid sequence-based amplification. The NASBA assay is an isothermal RNA-specific amplification assay that does not require the thermal cycling instrumentation. The initial stage is a reverse transcription in which single-stranded RNA target is copied to a double-stranded DNA molecule that serves as a template for RNA transcription. Detection of the amplified RNA is accomplished either by fluorescent labeled molecular beacon probes. NASBA has been adapted to dengue virus detection with sensitivity near that of virus isolation in cell cultures and may be useful method for studying dengue infections in the field studies. Next, we will speak about the detection of antigens. So until recently, detection of dengue antigens in acute phase serum was rare in patients with secondary infections, but such patients had previous pre-existing virus IgG antibody immunocomplexes. New developments in ELISA and dot blot assays directed to envelope membrane antigen and non-structural protein NS1 demonstrated that high concentrations of these antigens in the form of immune complexes could be detected in patients with both primary and secondary dengue infections up to 9 days after the onset of illness. The NS1 glycoprotein is produced by all flaviviruses and is secreted from mammalian cells. NS1 produces a very strong humoral response. So many studies have been directed at detection of NS1 to make an early diagnosis of dengue virus infection. Now commercial kits are for the detection of NS1 antigen are now available, though they do not differentiate between dengue serotypes. Their performance and utility are currently being evaluated by laboratories worldwide. Next, we'll speak about serological tests. The MAC-ELISA or IgM test. For the IgM antibody captured enzyme linked immunosorbent assay, total IgM in patient sera is captured by anti-mu chain specific antibodies coated onto microplate. dengue specific antigens from 1 to 4 serotypes, DENV1 to DENV4, are bound to the captured anti-dengue IgM antibodies and are detected by monoclonal or polyclonal dengue antibodies. Serum, blood on filter paper and saliva, but not urine, can be used for detection of IgM if samples are taken within the appropriate time frame, that is 5 days or more after the onset of fever. The MAC Elisa has a good sensitivity and specificity, but only when used 5 or more days after the onset of fever. The different commercial kits are available but have variable sensitivity and specificity. The WHO TDR PDVI laboratory network recently concluded that ELISAs generally performed better than rapid tests. MAC ELISA so cross reactivity with other circulating viruses such as Japanese encephalitis, St. Louis encephalitis, and yellow fever does not seem to be a problem, but some false positive results were obtained in sera from patients with malaria, leptospirosis, and past dengue infection. These limitations have to be taken into account when using the tests in regions where these pathogens co-circulate. It is not possible to use IgM assays to identify dengue serotypes, as these antibodies are broadly cross-reactive and even for cross-reactive even following primary infections. Now let's speak about IgG ELISA. The IgG ELISA is used for the detection of recent or past dengue infections. This assay uses the same antigens as MAC ELISA. The use of envelop by membrane specific capture IgG ELISA allows detection of IgG antibodies over a period of 10 months after the infection. The IgG antibodies are lifelong, as measured by envelope membrane antigen coated indirect IgG ELISA, but a 4-fold or greater increase in IgG antibodies in acute and convalescent paired sera can be used to document recent infections. The tests correlate well with the hemagglutination inhibition test. An ELISA inhibition method to aim IgG dengue antibodies is also used for the serological diagnosis and surveillance of dengue cases. This system is based in the competition for antigen sites by IgG dengue antibodies in the sample and conjugated human IgG anti-dengue. So this method can be used to detect IgG antibodies in serum or plasma and filter paper stored blood samples, and permits identification of a case as a primary or secondary dengue infection. In general, IgG ELISA lacks specificity within the flavivirus serocomplex groups. Following viral infections, newly produced antibodies are less avid than antibodies produced months or years after infection. Next, we'll speak about IgM to IgG ratio. A dengue virus enveloped to membrane protein specific IgM-IgG ratio can be used to distinguish primary from secondary dengue virus infections. IgM capture and IgG capture ELISAs are most commonly assays for this purpose. In some laboratories, dengue infection is defined as primary if the IgM to IgG ratio is greater than 1.2, using patient sera at 1:100 dilution, or 1.4 using the patient sera as 1:20 dilutions. The infection is secondary if the ratio is less than 1.2 or 1.4. This algorithm has also been adopted by some commercial vendors. However, ratios may vary between laboratories, thus indicating the need for better standardization of test performance. Let's talk about IgA. The positive detection of serum anti-dengue IgA is measured by anti-dengue virus IgA capture ELISA, often occurs 1 day after that of IgM. The IgA titer peaks around 8 days after the onset of fever and decreases rapidly until it is undetectable by day 40. There is no differences in IgA titers were found out by authors between patients with primary or secondary infections. Even though IgA values are generally lower than IgM, both in serum and saliva, the two methods could be performed together to help in interpreting dengue serology. This approach is not used very often and requires additional evaluation. The hemagglutination test, the hemagglutination inhibition test is based on the ability of dengue antigens to agglutinate red blood cells of ganders or trypsinized human ORBC. Anti-dengue antibodies in sera can inhibit this agglutination, and the potency of this inhibition is measured in an hemagglutination inhibition test. Each batch of antigens and RBCs is optimized. pH optimum for each dengue hemagglutination requires the use of multiple different pH buffers for each serotype. Optimally, the hemagglutination inhibition test requires paired sera obtained upon hospital admission and discharge, or paired sera with an interval of more than 7 days. The assay does not discriminate between infections by closely related flavivirus, for example, between dengue virus and Japanese encephalitis virus or West Nile virus, nor between immunoglobulin isotypes. The response to a primary reaction is characterized by low level of antibodies in the acute phase serum drawn before 5 days and a slow elevation of hemagglutination inhibition antibody titers thereafter. During secondary dengue infections, hemagglutination inhibition antibody titers rise rapidly, usually exceeding 1:1200. Hematological tests, platelets and hematocrit values are commonly measured during the acute stages of dengue infection. These should be performed carefully by using standardized protocols, reagents, and equipment. A drop of platelet count below 1 lakh may be observed in dengue fever, but it is a constant feature of dengue hemorrhagic fever. Thrombocytopenia is usually observed in periods between 3 to 8 days following the onset of illness. Hemoconcentration as estimated by increase in hematocrit by 20% or more compared with convalescent values is suggestive of hypovolemia due to vascular permeability and plasma leakage. So here is a summary of all the diagnostic tests. So virus isolation or virus culture, advantages are it is specific and gives reliable results. Disadvantages, it is time consuming, has lower sensitivity, it is expensive and requires facilities and expertise skills and requires acute samples. The RT-PCR technique, advantages are high sensitivity, high specificity, results are in less than 24 hours and results are reliable. The disadvantages are it is expensive, requires a special instrumentation, requires careful handling to avoid cross-contamination during RT-PCR procedure, involves hazardous chemicals, and it is the sample is required within in this acute phase within 5 days. Next, NS1 detection, advantages are it is inexpensive, results are rapid, within a few hours, it is easy to operate. Disadvantages are it has a lower sensitivity, high cross reactivity with another antigen antibody, false positive and negative results, but it requires acute sample within 5 days. And next, let's come to serological tests, IgG and IgM. Advantages are it is inexpensive, tests are rapid, results are rapid within a few hours, easy to operate. Disadvantages are it has lower sensitivity, high cross reactivity with other flaviviruses and antigen antibody, false positive and negative results, and require febrile samples. So let's discuss about some radiological findings in dengue fever. Ultrasound findings are hepatomegaly, splenomegaly, gallbladder wall edema, right-sided pleural effusion more than bilateral pleural effusions, and ascites are common findings. So the picture on the extreme left is a edematous gallbladder. The second picture is a right-sided pleural effusion. Third picture is a bilateral pleural effusion, and fourth one is ascites. CT and MRI brain findings in dengue encephalitis. So CT brain findings are hyperattenuating intraparenchymal foci representing spontaneous macrohemorrhages. The commonly affected brain regions in dengue encephalitis are basal ganglia, thalamus, cerebellum, cortical white matter, periventricular white matter, and cortical gray matter, which are all hyperdense on T2 weighted images and flare on MRI. Affected regions demonstrate restricted diffusion in most cases in diffusion weighted images and ADC. Lesions are iso or hypodense in T1 weighted images, and microhemorrhages appear as blooming on susceptibility weighted MRI. Dengue encephalitis can be diagnosed by the presence of evidence of dengue virus in the body confirmed by positive dengue virus culture and or dengue IgM antibodies in either serum or CSF or both. or presence of neuroimaging evidence suggestive of dengue encephalitis. The serotypes most commonly associated with dengue encephalitis are DNV2 and DNV3. So here are some images of MRI images in dengue encephalitis. Here the image A is representative of hypointensity in bilateral thalami in T1 weighted images. The second image is the image B is hyperintensity in bilateral thalami in T2 weighted images. C and D are intense diffusion restriction at center of bilateral thalami in diffusion weighted and ADC images with hemorrhage, and the last one, image E, represents hemorrhages in the center of bilateral thalami in SWI. So next, let's talk about dengue hemorrhagic fever. So dengue hemorrhagic fever is a severe form of dengue. Dengue hemorrhagic fever criteria includes dengue fever with minor and major hemorrhagic manifestations, positive tourniquet test, purpura, bleeding from mucosa, GI tract, injection sites or other sites. There is presence of thrombocytopenia, platelets, which is platelets less than 1 lakh. Objective evidence of increased capillary permeability, that is increase in the hematocrit by 20%. Then serosal effusions by chest, pleural effusions on chest X-rays or by USG abdomen, or ascites or USG lung. We can see serositis, polyserositis. Next, there is a presence of hypoalbuminemia. So there are grades of dengue hemorrhagic fever. Grade 1 fever. In grade 1, there is fever and non-specific constitutional symptoms with a positive tourniquet test being the only hemorrhagic manifestation. In grade 2, grade 1 manifestations plus spontaneous bleeding. In grade 3, there is circulatory failure manifested at rapid weak pulse with cold skin, restless and narrow pulse pressure or hypotension. In grade 4, there is a profound shock with non-detectable pulse or blood pressure. The grade 3 and grade 4 come into the category of dengue shock syndrome. So let's speak about dengue shock syndrome. It is the most severe form of dengue fever. The grade 3 and grade 4 of dengue hemorrhagic fever constitute a dengue shock syndrome. Criteria includes the same criteria for dengue hemorrhagic fever with evidence of circulatory failure manifested by weak and rapid pulse, narrow pulse pressure of less than 20, hypotension for the specified age, cold and clammy skin, restlessness, decreased or absent urine output. Next, let's talk about the systemic complications of dengue fever. There are various organs affected by dengue fever. In liver, we can see hepatitis and transaminitis. Unlike conventional viral hepatitis, patients with dengue have a high level of AST that is greater than ALT. This may be due to high release of high amount of IST from damaged myocytes during dengue infection. The causes are multifactorial and some of them are listed here. Direct effects of the virus can be one cause, adverse consequence of host immune response. Third could be compromised circulation and or hypoxia by hypotension or localized vascular leakage in liver. It can be due to drugs such as acetaminophen and herbal medicines. Next, co-infections with other viruses such as hepatitis A, B, C, and presence of any other liver disease such as alcoholic liver disease. So severe liver impairment in the late dengue may complicate the outcome of dengue by causing acute hepatic failure and contributing directly to severe bleeding as well as potentiating DIC. Next, system or organ is brain or CNS. The neurological manifestations secondary to dengue infection, including encephalopathy, encephalitis, myelitis, neuroophthalmic complications, polyradiculopathy, neuropathy, and neuromuscular complications were also seen in some patients. The causes include hypotension, cerebral edema, focal hemorrhage, hyponatremia, acute hepatic failure, and direct invasion of virus into the CNS. Other complications, other systemic complications include renal, in which there is acute renal failure, which is accompanying presentation in dengue shock syndrome or dengue-related acute hepatic failure. they can be acute tubular necrosis or hemolytic uremic syndrome. In CVS, we can find viral myocarditis, cardiomyopathy, bradycardia, and other arrhythmias. In respiratory system, we can see respiratory failure, pulmonary hemorrhage, pulmonary edema, pleural effusions, and ARDS. There is also rhabdomyolysis seen in eyes. Retinal vasculopathy, optic neuropathy, and optic neuritis can be seen. In GI, gastrointestinal tract, we can find acute pancreatitis, acute appendicitis, cholecystitis, and cholangitis. Hematological complications may include hemophagocytic syndrome, severe neutropenia. And secondary infections such as hyponatremia, albuminuria are some other complications associated with dengue. Next, let's come to management of dengue fever. So, based on the presentation and clinical features, the patients can be divided into 3 groups: Group A, Group B, and Group C. Where Group A patients can be managed at home. Group B patients need to be admitted to the ward, and Group C patients need to be admitted in the ICU. The Group A patients include the patients with dengue fever without warning signs. They can be admitted into the managed in the home on home basis or OP basis. Group B patients are subdivided into 2 types. One is patients without warning signs who have certain high risk presentations such as pregnancy, infancy, or elderly age, or presence of comorbidities such as diabetes, or they have inability to tolerate oral fluids, or have poor urine output, or they live alone and are away from hospital. The second type in this Group B are patients with warning signs, and the Group C patients are patients with severe dengue presentation. So let's discuss about each category's management. So management of Group A patients. These patients are patients who present with dengue without warning signs, and they are able to tolerate adequate volumes of oral fluids. The lab test advice are CBP daily. Treatment advice should be adequate bed rest, adequate fluid intake, paracetamol of maximum up to 4 grams a day for adults, and accordingly for children. Patients with stable hematocrit can be sent home. Monitoring, they require daily review of disease progression, decrease in WBC counts, effervescence, and warning signs. Advice for immediate return should be given if development of any warning signs are present. Return advice of management should be given. Example, a home care card should be written and given to the patients. Management of the Group B patients without warning signs but coexisting conditions such as pregnancy, high-risk patients, they need to be admitted in the ward. Lab should be sent daily. CBP should be sent daily. Treatment is encouragement for lot of oral fluids. If not tolerated orally, we should start IV fluid therapy with normal saline or Ringer's lactate at maintenance rate, which is 4 ml per kg per hour for first 10 kgs, then 2 ml per kg per hour for the next 20 kgs, and then 1 ml per kg per hour for remaining body weight. Monitoring, temperature patterns should be monitored, volume of fluid intake and losses should be monitored, urine output and volume and frequency should be monitored, warning signs should be monitored regularly, hematocrit, WBC, and platelet counts should be monitored on a daily basis. So Group B, now the management of Group B patients with warning signs. For them, we need to send CBP daily to see WBC counts and hematocrit. Treatments includes we have to obtain a hematocrit level before initiating fluid therapy. We should start with isotonic solution, starting with 7 to 5 ml per kg per hour for 1 to 2 hours, then reduce to 3 to 5 ml per kg per hour for 2 to 4 hours, and then reduce to 2 to 3 ml per kg per hour or less according to the clinical response. Then we have to reassess the clinical status and repeat hematocrit. If the hematocrit remains same or rises minimally, continue at 2 to 3 ml per kg per hour for another 2 to 4 hours. If worsening of vital signs and rapidly rising hematocrit, increase the rate of fluids to 5 to 10 ml per kg per hour for 1 to 2 hours. Then reassess the clinical status, repeat hematocrit, and reduce rate of fluid infusion accordingly. Reduce IV fluids gradually when the rate of plasma leakage decreases towards the end of the critical phase, which is indicated by adequate urine output and or fluid intake, and when hematocrit decreases below the baseline value in a stable patient. So monitoring vital signs and peripheral perfusion 1 to 4th hourly until the patient is out of critical phase. Urine output every 4 to 6th hourly. Hematocrit before and after fluid therapy, and then every 6th to 12th hourly. Other organ functions such as renal, liver, and coagulation profile as indicated. Now the management of group C patients, patients with warning signs, and any one of the following: severe plasma leakage with shock and or fluid accumulation with respiratory distress, severe bleeding, severe organ impairment. Labs are CBP and other organ function tests as indicated. Treatment of in this we have two types of two subsets, which are one is treatment for which is compensated shock, where SBP is more than 90 in normal mental status, and a hypovolemic shock where there is a severe hypotension and altered mental status. So the treatment of compensated shock, we need to start IV fluid resuscitation with isotonic crystalloids at 5 to 10 ml per kg per hour for 1 hour. Reassess patient's condition. If patient improves, IV fluid should be reduced to 5 to 7 ml per kg per hour for 1 to 2 hours, then 3 to 5 ml per kg per hour for 2 to 4 hours, then 2 to 3 ml for next 2 to 4 hours, then reduce further depending on the hemodynamic status. IV fluids can be maintained for up to 2 to 4 days. 1 to 2 days. If the patient remains unstable, check hematocrit after first bolus. If the hematocrit increases and or still high, repeat a second bolus of crystalloid at 10 to 20 ml per kg per hour for 1 hour. If improvement, then reduce the rate to 7 to 10 ml per kg for 1 to 2 hours. And continue to reduce the rates in the similar fashion as mentioned above. If hematocrit decreases and patient is still unstable, this indicates bleeding and need to cross match and transfuse blood as soon as possible. So now let's come to the management of hypotensive shock. We need to initiate IV fluid resuscitation with crystalloids or colloid solution at 20 ml per kg as a bolus for 15 minutes. If patient improves, gives the crystalloid colloid solution at 10 ml per kg per hour for 1 hour, then reduce gradually as mentioned previously. If the patient remains unstable, review the hematocrit after the first bolus. If the hematocrit is low, this indicates bleeding. We need to cross match and transfuse as soon as possible. If the hematocrit is high compared to the baseline value, change to IV colloids at 10 to 20 ml per kg as second bolus over half to 1 hour. Reassess for after second bolus. If improvement seen, reduce the rate at rate to 7 to 10 ml per kg for 1 to 2 hours, then back to IV crystalloids, and then reduce rates as mentioned above. If the condition still unstable, repeat hematocrit after second bolus. The hematocrit decreases. This indicates bleeding, cross match and transfuse. If hematocrit increases, remains high of more than 50%, then continue colloid infusion at 10 to 20 ml per kg as a third bolus over 1 hour, then reduce the rate to 7 to 10 ml for 1 to 2 hours, then change back to crystalloids, and then reduce at the rate as mentioned previously. Treatment of hemorrhagic complications, give 5 to 10 ml per kg of fresh packed red cells or 10 to 20 ml kg fresh whole blood. A special note, there is no clear clinical benefit that has been demonstrated with colloids over crystalloids, and there has been more adverse effects with colloids. So crystalloids are therefore the initial choice of resuscitation fluids in dengue shock syndrome. The fluid should be treated based on the clinical monitoring and serial hematocrit values. Normal saline and Ringer's lactates have been crystalloids of choice in dengue fluid resuscitation. Normal saline may be chosen for initial resuscitation in patient with or without hyponatremia and with the normal chloride levels. If patient has hyperchloremia, hyperchloremic acidosis, or hypernatremia, Ringer's lactate may be better choice. So transfusion of blood products. So Regarding the prophylactic platelet transfusion, several studies in adult dengue patients have shown that prophylactic platelet transfusion had no significant benefit over supportive care alone. The existing evidence suggests no role of prophylactic platelet transfusion in adult dengue patients with thrombocytopenia, but no active bleeding. More robust evidence is needed for pediatric dengue patients and patients with severe dengue. Many units consider transfusing platelets once the count is less than 10,000. Regarding platelet transfusion in patients with minor and major bleeds, currently there is inadequate evidence to prove or disprove the benefit of platelet transfusion in dengue patients with bleeding. However, most units do transfuse platelets if the patient has acute severe mucosal bleed, which is not controlled by supportive care. So some other interventions for bleeding in dengue patients. A study on 25 children with dengue hemorrhagic fever, grade 2 to 3 with active bleeding showed short-term control of bleeding with recombinant factor 7A, but there was no overall benefit. While intravenous anti-D globulin has shown some benefit in improving the platelet counts in dengue, evidence is insufficient to suggest benefit with intravenous immunoglobulin, interleukin-1, and tranexamic acid. Role of corticosteroids. There have been discussions on the role of corticosteroids in dengue shock syndrome and possibility of preventing progression to severe illness if given in early course. However, there is no evidence to support either of these. But corticosteroids have a role in dengue encephalitis since patients have been pulsed with pulse steroids have been done in dengue encephalitis. So management of systemic complications of dengue fever. For cardiac complications, dengue patients with myocarditis and cardiogenic shock need to be extremely careful with fluid resuscitation followed by early initiation of inotropic agents. That is because these patients are at high risk of developing congestive cardiac failure and pulmonary edema. Hepatitis and liver failure. This may manifest as hepatomegaly, jaundice, elevated transaminase, aminases, and acute liver failure. Management is similar to that of ALF due to other causes. Acute kidney injury, hypoperfusion, rhabdomyolysis, and hemolysis, apart from direct effects of dengue virus and immune-mediated injury, may lead to renal impairment in dengue. Management comprises of judicious fluid management to target a urine output of more than 0.5 ml per kg per hour and early renal replacement therapy when indicated. Continuous veno-venous hemofiltration is the preferred modality. Respiratory complications, pleural tap is best avoided in dengue. Rarely therapeutic pleural fluid drainage may be needed in situations where massive pleural effusion leads to inability to ventilate the child in pediatric group. Children with refractic shock have to be intubated and mechanically ventilated. Few children may develop ARDS. Lung protective ventilation should be initiated in this setting. CNS complications. Management remains supportive in form of adequate hydration, monitoring of consciousness, airway protection, anti-seizures medications in case of seizures, and raised intracranial pressure measures if clinically indicated. Intravenous IVIG may be useful in post-dengue GBS. Pulse steroids may be helpful in immune-mediated complications such as ADEM. However, data are insufficient. HLH, secondary hemophagocytic lymphohistiocytosis. Secondary HLH is a potentially fatal complication of dengue characterized by a hyperinflammatory state due to the uncontrolled proliferation of activated lymphocytes and production of pro-inflammatory cytokines. Treatment with IVIG or corticosteroids have been shown to lead to improved outcomes. Early recognition is imperative for the favorable outcome. Let's talk about drugs and vaccines. There is, as per drugs, there is no antiviral drug currently approved for the treatment of dengue. However, several potentially efficacious anti-dengue virus drugs are currently being tested in humans and are at various stages of development. Anti-dengue vaccines. The development of anti-dengue vaccine is urgent priority owing to the lack of specific antiviral treatment against dengue. Currently, 5 types of dengue vaccines are under development: live attenuated virus vaccines, inactivated virus vaccines, recombinant subunit vaccines, viral vector vaccines, and DNA vaccines. The ones furthest in development are live attenuated vaccines. namely Dengvaxia, completed the phase 3 trials. Efficacy is of around 59%. The TAK 003, it is in phase 3 trial. Efficacy has been shown to be around 80%. And the TV003 and TV005, it is in phase 2 trials with efficacy of 70 to 90% in flavivirus naive individuals who have never been exposed to flavivirus. So prevention of dengue, we can use insect repellents, use mosquito repellent skin lotions, wear long sleeved shirts and long pants, control mosquitoes inside and outside our homes and workplaces by destroying the mosquito breeding places, use by using mosquito nets and mosquito bats and other equipment available in the market. So these are the prevention methods. Take home message: dengue fever is a fever caused by dengue virus or flavivirus class. Disease ranges from mild fever to severe dengue fever, which is fatal. Dengue hemorrhagic fever, hemorrhagic or dengue shock syndrome is the most severe form of the disease involving multiple organs. Mainstay of treatment is supportive care. Crystalloids are the initial choice of fluids of choice. Corticosteroids have no role in the treatment of dengue. There is no clear guideline on cutoff for prophylactic platelet transfusion, though we transfuse or some centers transfuse at 10,000, and corticosteroids, as mentioned earlier, have been used in dengue viral encephalitis. And development of effective vaccines and drugs is the need of the hour. Prevention is better since there is no definitive cure yet. Thank you. That will be also.
Thank you, Dr. Naveen, you want to add?
Sir, it was a elaborative presentation. So 2-3 things. One, there is no role of papaya extract, which is used for almost every patient of dengue. Two, I wanted to ask you, sir, actually, is there any way by which we can risk stratify these patients? Whenever we talk of dengue, I still remember a physician who we lost last year because of dengue. Her IgG was positive, but we never expected we would lose her. She went into acute hepatic failure. So I still feel that we need a scoring system for risk stratification of these patients. And 3, there is no role of colloids. Crystalloids should be used, and crystalloids are the only fluid. Even though some guidelines mention that colloids can be used, there is no role of colloids. Done, sir.
Yeah, see, we need to understand the pathophysiology of dengue a little bit more. The initial febrile phase of the uncomplicated simple dengue is also associated with thrombocytopenia, as it happens with all other types of viral syndromes, whether you have a viral hepatitis, whether you have varicella infection, there is some amount of bone marrow involvement, and there is some amount of thrombocytopenia in all viruses. So that thrombocytopenia should not be treated or viewed on par with the thrombocytopenia that happens with complicated or severe dengue syndrome. If you look at what Ahad presented, while you say that the pathophysiology of dengue is because of a capillary leak syndrome, it does not behave like the capillary leak of sepsis because the pulse pressure in dengue is narrow. So it is more of a persistent vasoplegic state and a myotoxic phase, maybe of the vascular smooth muscle, may or plus or minus the cardiogenic depression. So the approach to the patient who has a thrombocytopenia with a complicated dengue is a little different. And there are some small studies which have demonstrated an absolute deficiency of ADAMTS13 in patients with severe dengue, especially those with dengue shock. In such patients, no amount of thrombocyte transfusion, that is platelet transfusion, will reverse the thrombocytopenia unless you replace the ADAMTS levels in these patients. Actually, the cryosupernatant is the biggest source of this plasma, the ADAMTS13, but because of lack of availability of plasma, the cryosupernatant. FFP is the second best source. The FFP is the second best source of Adam DS13. So, if you are believers in giving, if you are believers in giving platelets for patients whose platelet counts are less than 10,000, you should always, especially in the severe forms of dengue, you should always supplement them with FFPs, at least 2 FFPs for every unit of STP ratio transfusion. As far as scoring systems are concerned, there are certain predictive factors by which patient will develop the severe dengue and which patient will not develop the severe dengue. It is not the platelet count. It is not the platelet count which determines whether the patient will develop a severe form of disease or not. But it is the liver function deterioration which predicts which patient will deteriorate faster and which patient will deteriorate slowly or will not deteriorate. Somebody who has a sequential rise of 1.5 to 2 times the HGPT within 12 hours or within 18 hours or 24 hours is somebody who's going to do worse in the context of severe dengue. So if you look at scoring systems, early onset of myocarditis, early onset of transaminitis, and early onset of neurological manifestations are considered to be poor markers for predictors of severe form of. So it is still an uncharted territory. There are people who have got themselves vaccinated with dengue but still got infected because just like other viruses, this virus also mutates and mutates badly. So we don't know where it is going to head. But having said that, it's been an excellent presentation. I think a lot of new points and new perspectives have been presented today. Thank you all for joining. We are taking a break next week because we are all traveling to Indore for the national conference, and we will be back the 28th of February with the next series of next talk on tropical diseases. Till then, take care.
Thank you, sir.